Hello, everybody, and welcome to another session on point of care ultrasound for focus. And today we will discuss about sonographic approach to respiratory failure. In next 30 minutes or so, we will see how we can use ultrasound in the diagnosis, monitoring, and management of patient who presented with a unknown cause of respiratory failure. Myself, Dr. Sudipto Mukherjee, working as a critical care consultant in Tata Medical Center, Calcutta, and this is one of my area of interest. So we'll start with a case. A 60 years old lady, known case of diabetes and hypertension, on medical management and with reasonably under control. He has underlying acute lymphoid leukemia and for which she has received chemotherapy recently. Now, she was admitted to the ward with shortness of breath. Initially, she was managed with supplemental oxygen and antibiotics as per hospital protocol. With worsening hypoxemia, patient was shifted to ICU. She got immediately intubated, ventilated, now requiring FiO2 of 0.8 to maintain saturation around 1992. We did a chest X-ray at the bedside. It shows bilateral haziness. Now CT scan cannot be done because very difficult to shift this patient with a transport ventilator to the CT suite. Now what? Can ultrasound lung help in assessment and evaluation of this patient? Now, whenever we are talking about lung ultrasound, we usually use two types of probe. One is linear and one is curvilinear. The linear probe, it is used for surface assessment. It is high frequency, better resolution, but poor penetration. So, it is used for skin, subcutaneous tissue, pleural, and subpleural areal assessment. On the other hand, the curvilinear probe, which has a lesser frequency but better penetration and poor resolution, has been used for the deeper structure of any organ. Here, for lung ultrasound, we will use it for evaluation of base of the lung, diaphragm, and subdiaphragmatic area. And also, there is another challenge whenever we are doing a lung ultrasound. So, mostly in a standard ultrasound machine, there is a setting which suppresses routinely developed artifacts. But we know lung ultrasound is basically the interpretation of artifacts. So we need to do some dedicated changes in the software of the ultrasound, which is called lung preset. At the same time, we have to turn off compound imaging and harmonic imaging, and also have to reduce dynamic range to get better clarity for lung ultrasound. Whenever we are doing lung ultrasound, we have to describe our finding in an objective manner. For that, we have to divide the lung on each side into 6 zones. You can see in the picture that is zone 1, zone 2, zone 3, zone 4, zone 5, and zone 6. Now, it has been separated by 3 vertical lines, that is the lateral border of the sternum, anterior axillary line, and the posterior axillary line, and a horizontal line which passes through the 4th intercostal space at the level of the nipple. So by this, we can divide the lung into depicted area. And also, whenever we are looking at the base, we have to do some modification in the setting. The ideal depth for assess the base of the lung is 9 to 11 centimeter anteriorly and can be 15 centimeter at the base. Too much depth, if you develop, then we cannot see the pleura. And we need to place the probe perpendicular to the pleura for better delineation. If the probe is out of plane, you may get a pattern which is called non-A, non-B pattern. That is, you are not able to see A lines, neither you can recognize any B lines. So that means the probe is not in the vertical plane with the pleura. Now we know that evaluation of the lung by ultrasound is like identifying the tip of the iceberg. If the underlying lung pathology has some pleural representation or subpleural representation, only then we can identify the pathology with lung ultrasound. Otherwise, it will not be possible to pick up. But luckily, nearly 95% cases, the underlying lung pathology, which leads to an ICU admission or emergency admission, has a pleural representation. So most of the time, we can able to pick up certain positive findings. So whenever we are going to scan the whole this all the areas of the lung, that is this 12 area, including both sides. First, we'll evaluate this area longitudinally, as you can see the position of my probe. And once I identify any abnormality, we'll turn my probe, put it in between the two ribs, and evaluate it in detail in the transverse axis. So lung basically developed by two types of image. The upper part, that is from the skin up to the pleura, are true image because of the presence of tissue through which ultrasound can pass. And below pleura, it is because of the artifacts, because the ultrasound wave cannot pass through the air. Whenever we are describing any lung ultrasound finding, or at the same time, if we try to interpret it, we have to interpret it in a pathophysiological manner. No ultrasound finding in the lung can diagnose the etiology directly. Most of the time, it will give us some pathophysiological understanding, which we have to utilize in our clinical background. And we have to conclude about the anticipated underlying pathology. So here we can see the upper part of this picture, that is from the skin, subcutaneous tissue, muscle, and up to this shiny structure, which forms by the tissue-air interface, that is at the level of pleura, are true image. Below pleura, these are artifacts. Here we can see a hyperechoic margin followed by black shadow. This is because of the ribs. Ultrasound cannot pass through bones also. And when you describe this finding in a classical manner, this is called bat-wing appearance. Here you can see a hyperechoic structure line, and in both sides there will be black shadow. And below this hyperechoic line, that is pleura, you can see multiple horizontal lines, which is called E lines. It looks like a bat. Now, if I want to describe this ultrasound finding, these are called A lines because they are produced by reverberation artifact of the ultrasound beams at the level of pleura. These are horizontal lines parallel to the pleural line. It is separated by regular interval, which are equal to the distance between the skin and the pleural line, and it is seen in normal and aerated lung. At the same time, we need to remember this finding can be present even if the air is situated outside the lung, that is within two pleural layers. A lines indicate there is air below the ultrasound probe. Now, whether this air is present within the lung or in between the two pleural layers can be differentiated by lung sliding. The lung sliding is due to the relative movement between the parietal and the visceral pleura during breathing. You can recognize the to and fro movement of this pleural line during breathing. It indicates that both pleural layers are in a position and air is present within the lung. If you want to confirm this movement, you can put an M mode through it and you'll get a picture like this. That is the skin and subcutaneous tissue, which are immobile, will give horizontal stripes, and the lung below the pleura, which is moving, will give you an apparent granular pattern because of its movement. This is called seesaw sign, which indicate normal aerated lung below the pleura. But in our case, what we found after putting the ultrasound probe, like this, these are hyperechoic, well-defined laser-like lines, which is also described as comet shape. It emerges from the pleura, or if there's a consolidation just below the pleura, these vertical lines can emerge from those consolidations also. It extends up to the edge of the skin, that's at the base of the skin. These are moving with pleural line and also with respiration, and these are obliterating the A lines or horizontal lines. These are called B lines. What B lines indicate? B line indicates there is a deaeration of the underlying lung. So whenever there is B line present, first we have to know whether these are acute or chronic. if we have a previous lung ultrasound finding from which we can differentiate whether it's acute or chronic. In chronic lung disease like interstitial lung disease, B lines can be present in chronic cases or chronic lung diseases. But let's consider in our patient, it is an acute finding. Now, in that situation, when there is a deaeration or pulmonary edema, we need to know whether it is cardiac or non-cardiac in origin, because the treatment will be different. So if it is because of cardiac origin, it should equally distribute both lung or involve both lung. In that case, the B lines should be homogeneous. Because these are hydrostatic edema, so there should be gravitational distribution. That means the number of B lines, which indicate the severity of deaeration, should be less in the superficial part or upper part and should be more at the base. The pleural line, because there is no pathology, should be smooth, and there should not be any subpleural consolidation. So in the first picture, you can see these are pleural lines, smooth, multiple vertical B lines. Is probably in a cardiogenic pulmonary edema. On the other hand, here you can see there is subpleural consolidation and there are vertical B lines starting below the consolidation. This indicates non-cardiac or pulmonary cause of B lines. Now in day 2, there is a new onset sudden desaturation to our patient. There is an apparent worsening of the respiratory function with increase in FiO2 to 100. Now what can be the cause and how ultrasound can help to evaluate the underlying pathophysiology? So whenever we are evaluating this type of sudden desaturation, we usually look at the airway followed by look at the lung. So first thing we need to confirm whether ET tube is in position or not, whether it is within the trachea. Now with a scan of the anterior part of the neck, if we identify the trachea and the tracheal lumen, we can clearly identify whether there is any artificial tube present or not. Because endotracheal tube is filled with air, the cuff surrounding is also filled with air, you may not be able to identify its real image. But with small amount of to and fro movement, you can clearly appreciate that there is an undulating movement happened within the trachea. It indicates that the tube is within the tracheal lumen. Now, if it's compared the image on the right of the skin with the left, you can see that shiny structure, shiny tubular picture that can be identified in the left image is present in the right side outside the trachea, that is lateral and behind the trachea. It clearly indicates the tube is in the esophagus. And with movement, you can see undulation here rather than here. It will confirm that the tube is not in position and presently in the esophagus. And it's just like when the endotracheal tube, right tube is present in the esophagus, we can see picture like that. But the endotracheal tube is thicker, so we'll get a larger structure, apparently larger structure. Next thing we need to confirm whether the tube is in the trachea or within the bronchus. We know mostly if it is the endobronchial intubation, it will go to the right side because of its anatomical position. Now, if the tube is in the right side of the lung, what will happen? Right side of the lung will get ventilated like normal lung. But what will happen to the left side? In left side, here you can appreciate there is an undulating movement happen at the pleural level, but the rate of this movement is much higher compared to the respiratory rate. And the pleural sliding is conventional pleural sliding, which is present in the right side of the chest, is absent. This is called lung pulse. This happens because of transmitted pulsation of the cardiac oscillation up to the pleura, as the underlying lung is not getting ventilated. And also because the underlying lung has air, it will give a pattern. This confirms that the endobronchial intubation and indicates that the tube needs to be repositioned. Another complication that can happen is subcutaneous emphysema. Now, if you get a picture like that, the patient is absolutely bloated up because of the air leaking from the lung into the subcutaneous space, which indicates an underlying pneumothorax as the cause of hypoxemia, diagnosis is very easy and our life is very smooth. In a trauma scenario, even without a pneumothorax, you can get a picture like that. If there is an injury to any air-containing lumen and air leaks into the surrounding subcutaneous tissue, you will see hyperechoic vertical lines. Those are starting from the tissue, not from the pleura, and going up to the base of the screen. And they are starting from different level within the tissue. Next, that we already know the patient has multiple V lines, probably because of a pulmonary edema, non-cardiogenic pulmonary edema. So there can be a worsening in the pulmonary edema during the course of the disease. If you can see the picture to the extreme left, there are 2 or 3 V lines can be visible within a certain lung zone or under the ultrasound probe, which has progressively increased to confluent V lines, followed by a white area which has been developed because of the very close proximity of the V lines. Now, it clearly indicates there is a progressive increase in the deaeration from left of my screen to the right, and there is a worsening in the pulmonary edema. So, you can see ultrasound beam can be used to follow up the severity of the disease and also in terms of progression of the disease. Now, there can be some challenges, as I already mentioned. If the patient has a B profile, that is lung sliding with a vertical hyperechoic lines or the comets, with a regular pleural line, it's a cardiogenic pulmonary edema. That is going to be acute decompensated heart failure. If the patient has B lines with irregular pleural line, probably these are non-cardiogenic pulmonary edema, maybe because of ARDS, severe pneumonia. But what if the patient has a profile with an irregular pleural line? We are not sure about its clinical significance. The pneumothorax, when it is present in the tissue as a subcutaneous emphysema, you know the finding, will get E lines. What will happen to the lung? Again, we have to approach in a physiological perspective. As there is a separation of the parietal and visceral pleura, the lung sliding will be absent. If you put a M mode, we will get a stratosphere sign. That is that the whole screen length of the screen, including the tissue and the lung, will show horizontal stripes or like a barcode. Because the underlying lung does not present, there's the air outside the lung, so lung pulse cannot be present, lung pulse is absent. You are not going to see any B lines, and A lines may be present because the underlying place has some air, and in certain situation, you may get lung point. Lung point is developed because at the site where parietal and visceral pleura get separated. It is a transient point between the mobile and the immobile lung, as you can clearly identify in the picture. And it is reasonably specific for diagnosis of pneumothorax. But diagnosing pneumothorax with an ultrasound has its own challenges. It can be false positive or false negative. Because if you follow the lung sliding, the port lung sliding, the quality of the lung sliding will worsen. Lung sliding will become more and more poor with the increase in the depth. There can be other causes of lack of lung sliding or inadequate lung sliding, like severe COPD and emphysema, underlying lung bulla present below the pleura. Patient may be apneic, post-pleurodesis, patient may be having very high peak and low tidal volume, so the lung excursion is very, very limited. Patient may have endobronchial intubation, and sometimes in morbidly obese patient, when the distance between the skin and the pleura has increased significantly. And if by accidentally I'm scanning over the rib, it also gives a false absence of lung sliding. On the other hand, there can be reason where we get a false negative finding, like maybe a trapped pneumothorax, which may be missed by a rapid ultrasound scan, someone not been picked up by the probe. The ultrasound pneumothorax may not follow the path of the lung pulse or the way we are evaluate the pneumothorax, and we know the severity and the extent of pneumothorax may be missed with ultrasound. And this has already been discussed. If there is a subcutaneous emphysema or pleural pneumothorax expanded into the subcutaneous tissue, what we'll have, we can see vertical nasal lines, which apparently looks like B, but starting from different level of the skin, not from below the pleura, and level reach up to the base of the skin. These are different from the B lines, are called E lines. There are another type of vertical lines which are called Z lines. We need to remember that all vertical hyperechoic lines are not B lines, not indicative of pulmonary edema. Z lines means these are vertical lines which are starting from the pleura for sure, but does not reach up to the base of the spleen, and they do not obliterate a pattern of the lung. They does not have any clinical significance. So we have to differentiate between B line, Z line, and E line in lung ultrasound. Ultrasound can also be used to see severe pleural effusion as a cause of hypoxic respiratory failure. Have to put the probe at the base of the lung, maybe at the zone 4 and zone 6, and you can clearly see the effusion as a hypoechoic structure because ultrasound can pass very well through the fluids, and you can see the collapsed lung inside it is floating. If I put a M mode, you will see a picture like that, which is called sinusoidal sign. That means the lung is coming and going from the probe. And because of the effusion, the underlying lung may be atelectatic. If there is an atelectasis, the lung will appear as a solid structure. There may be small hyperechoic dots present within the lung because of trapped air within it. These are called static air bronchogram. And static air bronchogram is suggestive of collapse. Once you get a picture like that, we may need to drain the fluid and see whether the lung getting ventilation or not. But if there is a hydropneumothorax, that is air and fluid present the same side, the interpretation can be little tricky because there may be a movement of the air and pleural effusion interface indicating a lung sliding. Sometimes in ultrasound, it may appear like that. At the same time, if there's a bubble placed in the air effusion interface at the parietal pleura, you may get some vertical reverberation artifact, mimicking like a B lines. So identifying hydropneumothorax with an ultrasound can be tricky and is one of the drawbacks of lung ultrasound. If there is a consolidation, what will happen? The underlying lung is solidified, but the airway which conveying the air up to the lung are open. So we'll see something like this, which is called dynamic air bronchogram. Dynamic air bronchogram is confirmatory for underlying consolidation. Now, if the consolidation or the pneumonia is under evolution, then you will get a small effusion. A part of the lung is solidified, and below that, probably the aeration has significantly increased. So this pattern, when there is a solid lung and below which B lines has been developed at different level, which is called thread sign. This is also diagnostic finding for pneumonia. Sometimes identifying pneumonia with the lung ultrasound can be a little tricky. We have to know the pros and cons. Like as I already mentioned, if the pneumonia does not have any pleural representation, it may be missed with an ultrasound. And it has been shown that up to 1.5% cases of CT documented pneumonia have been missed with an ultrasound. And sometimes the full stomach on the left side may falsely diagnosed as a consolidation because the appearance may be little similar. So whenever you are getting a consolidated structure like a bag with multiple hyperechoic dots within it, need to rule out full stomach. This ultrasound can also be used to check for collapsibility, the recruitability of a collapsed lung. So in this situation, we can clearly see there is no improvement in the aeration of the lung during respiratory cycle. We can review it again after drainage of the fluid. Now, if it is because of compression atelectasis because of the fluid, it should open up a bit. We have to give an incremental PEEP to open up the lung. But we also need to remember the optimum PEEP may not be able to confirm by an ultrasound because ultrasound cannot diagnose hyperinflation. So whether the lung is optimally inflated or hyperinflated, we cannot differentiate with lung ultrasound. And regarding the de-aeration, there are objective scoring systems which try to measure the recruitability and the aeration status of the lung. These are called this is called de-aeration index. This is one of the examples. There are multiple other scoring systems which has a score from score 0 to 03. 0 means much more amount of air and 3 means more de-aeration. Now, in a patient, if you do a recruitment maneuver or increase the PEEP, and the over de-aeration index or de-aeration score decreases from maybe 3 to 0 or 3 to 1, That means there is a small amount of recruitment that has been happened. And by the same technique, we can follow a severe pneumonia and can see whether the patient is having any improvement with your management or not. If there is a decrease in the deaeration score and deaeration index, that means the underlying lung is getting more and more aerated and the patient is improving. Now we can see from the physiological aspect, pathophysiological aspect, what can be the finding in pulmonary embolism. Now in pulmonary embolism, the pleura is normal. There is presence of parietal and visceral pleura. So there should be lung sliding because the underlying lung is moving. Underlying lung is properly aerated, so we will get a pattern. And so our suspicion will generate when you get a normal lung, a pattern lung with lung sliding and horizontal lines with the patient who is severely hypoxic. In that situation, we have to think of a pathology of the vascular system. At the same time, in certain situations, you may get some subpleural consolidation because of infarct. And one of the structured way to express or use this knowledge for the diagnosis of acute respiratory failure has been generated by the father of lung ultrasound, that is Daniel Lichtenstein, which is called Blue protocol. Here, in a structured way, we look at the lung sliding, presence of A pattern or B pattern. Along with that, incorporate the scan of the lower limb to rule out DVT. By this, we can diagnose whether the patient has a pulmonary edema, pulmonary embolism, pneumonia, or pneumothorax, or exacerbation of COPD asthma as a cause of respiratory failure. Now our case continues. By day 9, patient is clinically better. We try to wean him off the ventilator. Pressure support mode was tried with 2 by 8 centimeter of water. She was generating only 250 ml of tidal volume, becoming tachypneic with a respiratory rate of 35. Now what? Can ultrasound be used for evaluation of the cause of weaning failure? So now there are a lot of data are coming where ultrasound has been used for evaluation of the diaphragmatic function. We know in sick patient who is in prolonged ventilation requirement, received drugs like muscle relaxant, cholesterol, steroid, they develop profound neuromuscular weakness, and because the diaphragmatic weakness can be one of the cause of weaning failure. Here, what we can do with the use of the ultrasound probe by the help of M mode, we can measure the movement of the diaphragm, the absolute movement of the diaphragm, and also we can look for the thickening of the diaphragm during contraction. If these are not satisfactory, probably the neuromuscular weakness of the diaphragm is the cause of weaning failure in our patient. Sometimes non-visualization of the diaphragm can be challenged. When you're looking at the dependent part, sometimes it gets obscured by the rib shadow and sometimes difficult to get the whole length of the diaphragm. What we have to do, we have to put the probe, the curvilinear probe, in between the intercostal space along the curvature of the rib. The journey of the rib in the lateral wall of the chest is usually oblique. So you have to put our probe appropriately to avoid the rib shadow. And in the left plaques view, we have to go further behind. That is, we have to avoid the shadow of the stomach and look up the lung behind the stomach. In the rightmost picture, you can clearly see the stomach is coming in front of the spleen and liver, lung. Whenever we are planning to extubate, sometimes make the patient NQ for a long duration. That can be avoided if you know how to evaluate the pandial status. We can do an NG aspirate just before extubation and do an ultrasound and see whether the stomach is still having fluid or food present or not. So mostly what we do, we focus on the antral area, which is just subxiphoid. If there is no content or no fluid is present, you will find that two wall of the stomach are approached. Now, once you give certain amount of fluid, you can see the antrum may become enlarged like a circular muscular structure. Now, depending on the type of the fluid, the type of the food, the internal structure will appear. If the clear fluid, you will picture like that hypoechoic structure. If the patient has a thick fluid, solid food, there may be trapped air, which gives a starry sky appearance. There are multiple white dots present within this fluid. Here we can see with the ultrasound, we can clearly identify the presence of Ray's tube. So ultrasound can help to confirm that your Ray's tube is in position. In the right picture, you can see there are multiple hyperechoic dots present in the antrum, indicating that there may be a semi-solid type of feed along with trapped air that happened during chewing. Now, post-extubation, patient developed a stridor. Can this be predicted? We know that with the help of the ultrasound, pre-intubation, we can measure or anticipate what should be the ideal diameter of the endotracheal tube, which avoid overzealous insertion of a larger size tube leading to airway edema and post-extubation stridor. This is more applicable for a pediatric patient when the margin of safety is very, very less. For adults, this has very limited clinical utility. Beside all this, ultrasound, if we fail to extubate the patient or there is an acute loss in airway, ultrasound can be used for utilization of surgical airway also, even in an acute emergency. One of the examples is cricothyroid. Here, with the ultrasound probe, we can clearly identify the cricothyroid membrane and can do the procedure in an out-of-plane approach. Here you can clearly identify, we can see the cricothyroid membrane, and as the needle is coming from here, there will be an undulation creating here. And eventually, it will pass the needle. Cricothyroid membrane. Yes, can be used for the tracheostomy also, including percutaneous tracheostomy, which is a very standard procedure in ICU. Here again, you can clearly identify an undulation is coming from the top of the spine, and eventually it will puncture the intertracheal septum. The journey of the needle will appear as a hypoechoic dot with undulating movement, because ultrasound beam has cut a part of the shaft of the needle or a part of the tip of the needle, and because it is out of the plane, we cannot see the whole length of the needle. So to summarize, if you look at the use of lung ultrasound, it can be used in clinical practice to rule out endobronchial intubation, to diagnose pulmonary edema and interstitial lung syndrome, pneumonia, pleural effusion, atelectasis, pneumothorax, pulmonary embolism, and can be used for thoracocentesis, and also occasionally for the biopsy of the pleural lesions and peripheral lung tumor. Advantage of ultrasound, we all know, it's a bedside diagnostic tool, can be used for rapid assessment. It minimizes complication related to transfer of the patient. No radiation exposure. It can be used repetitively without any extra cost. Only the recurring cost is literally zero. You just have to procure the machine with the capital budget. Compared to the conventional leaf, it has a very small learning curve. It has a very high sensitivity and specificity for diagnosing acute clinical conditions that leads to respiratory failure. By this, I'd like to complete my presentation. If anybody has any doubts or query, feel free to send me a message.